So in this video we're going to talk about disorders of the vagal nerve, and because the accessory nerve is very closely associated with the vagus and the two are often commonly affected together, we're going to include that. So the vagus nerve has many functions. It is afferent to the pharynx, the larynx, esophagus, the thoracic and abdominal organs. It's efferent to those abdominal organs and also the meninges. It has some special visceral efferents to the palate muscles and the pharyngeal muscles and the esophagus. And it has some somatic efferents to the meninges, the external ear where it joins the facial nerve, and it does proprioception of the laryngeal muscles probably, and special visceral afferent, which is taste of the pharynx. One thing we're not going to talk about here, though it's an incredibly interesting subject, is the effects of the microbiome and that bidirectional pathway between the microbiome, the vagal nerve and the brain. That really deserves a whole lecture onto itself. So we're just going to be dealing with structural problems of the vagal nerve in this lecture. So the nuclei for the vagal nerve are really three. The main one is the nucleus ambiguus, which is a broad and as the name would imply, not a well-defined nucleus. The front part of it does the glossopharyngeal nerve, the middle part does the vagal nerve, and the back part does the accessory nerve, and it also continues down the spinal cord, which forms the extrinsic nerve of the accessory nerve. There is also the parasympathetic nucleus of the vagal nerve, because obviously this is a main function of this nerve is a parasympathetic nerve. And then we also have the solitary nucleus, which is the sensory nucleus getting inputs from the visceral and the baroreceptors, chemoreceptors, taste, etc. There's a little summary for those that want to have that in text. Now, from a clinical point of view, one important phenomenon is the jugular foramen and the tympano-occipital fissure. This is the means by which the glossopharyngeal, vagal and accessory nerves leave the skull. And it's demonstrated in the CT here. So the jugular foramen is to the side of the tympanic bulla, and the fissure is kind of behind and medial to it. And these nerves leave this fissure, and it is at this level that these nerves can be damaged, typically by cancer. And so a lot of the diseases that we see are involving these foramen, and so much so that it's given a name, the jugular foramen syndrome. And so the nerves are leaving here via the jugular foramen, which becomes the tympano-occipital fissure, which you can just see here. This is the tympanic bulla here. This is the ventral surface of the atlas, and it kind of continues down here on the ventral surface of the atlas, that being the vagus nerve, which has been joined by a branch, the internal branch of the accessory nerve. So when dealing with the anatomy, the vagus nerve is leaving, joined by this internal branch of the accessory nerve before it exits the skull, and we can just see its image here on this cartoon, and then it sends off a branch to go to the ear, which joins the facial nerve, and there's also a branch going off to the pharynx and the cranial laryngeal nerve, and then it does a little bit of funky anatomy. The recurrent laryngeal nerve, which is the most important nerve to the larynx, actually hooks round the aortic arch on the left and the subclavian artery on the right and goes back up to the larynx. Some people think this is a really weird thing, a weird anatomy, and I guess it is, but it comes back to the fact that the larynx is the kind of evolutionary equivalent of the gills in the fish. And if you think the gills in the fish are directly opposing the heart, and so that innovation used to go just straight out this way, but because the larynx is more cranial in mammals compared to the gills in fish, then this nerve hooks back up and goes cranially. And this is important because the recurrent laryngeal nerves are the longest nerves in the body, which means that they're more susceptible to some pathologies, which we'll talk about later. And then, of course, the vagal nerve sends off all of these branches to all of the abdominal organs. So what are the clinical signs of vagal dysfunction? And I'm really going to stick here to the clinical signs that I have seen as a clinician. Theoretically, we could get changes to gut function, and heart function, but this is not something that I tend to recognize, perhaps as a deficiency in my clinical ability. But these are also the signs that are most commonly reported in papers. So the single most important sign is stridor, that's an inspiratory noise, or snoring as a new sign. Now, many brachycephalic dogs snore on a daily basis, but if your dog didn't snore and has now started to snore, then you have to question whether or not there is something wrong with their larynx, and laryngeal paralysis due to a vagal nerve problem would be one of those differentials. You can also have a chronic cough, gag, or retch, and this is because of saliva accumulation. And saliva accumulates around the larynx, and because your larynx and your back of your pharynx is not working so well, then this makes you cough and it can make you gag. Dysphonia is a change in the pitch of the bark or the meow. You may notice that the laryngeal paralysis is so bad they have a inspiratory dyspnea, or you may notice that they have more of a swallowing problem, or that they're just spending a lot longer actually eating. So sometimes people are not, in the early stages, don't notice that the animal is having difficulty swallowing, just they're taking longer to eat. Now, unfortunately, many of these diseases are due to tumours, and in many cases there is a mass in the neck that is palpable. And so if you suspect this, it's important to include that as your as part of your clinical exam. And then potentially megaesophagus, although in preparing this lecture I went back through all of my cases and I couldn't find a single case of megaesophagus due to a structural problem in the vagus nerve. I'm sure it must exist, but you have to bear in mind that diseases like congenital idiopathic megaesophagus, the vagal innervation is normal, and the most common causes of megaesophagus are neuromuscular diseases. Just like with dysphagia, the most common cause of dysphagia, an eating problem, is also neuromuscular disease rather than vagal disease. So here is an example of the stridor. It's a high-pitched, harsh sound caused by turbulent airflow in the upper airway, and this dog is having this whilst he's sleeping. It's usually heard on inspiration. Some of the noise here is his toenails on that laminate floor, but you can see how much of a stridor he has. And this indicates airway obstruction due to laryngeal paralysis, laryngeal edema, foreign body, or masses in that area. Important also to look at the gag reflex, which we can see in this little dog here. Now, on a video, this doesn't look so bad. It's really a sense that you've of how strong the reflex is when you feel it. And this little guy, he subjectively felt like he had low jaw tone and that his gag wasn't strong. And actually, in the latter part of this video, you can see he puts his paw up to push my hand away, and most dogs would have kicked my hand out of their mouth. He's got multiple cranial nerve deficits. He had diseases of the cranial nerves from 2 right through to 11, possibly even 12. And so his jaw tone was reduced because of a cranial nerve 5 problem. His gag was poor, probably because of a glossopharyngeal and vagal nerve problem. He had a slight tendency to turn his head to the left, which may have been an accessory problem. And his tongue had a tendency to deviate to the right, which you can see here. I'm not sure about this, but it may be that he has or is developing an hypoglossal problem. You can just see also here the mild temporal atrophy. Here an assessment of his larynx under sedation, and it must be under sedation, not full anesthesia, otherwise you'll paralyze the larynx. And I put them. Now I put the noise in the background here, really to show you that when you're taking a video of this, you really need, and when you're assessing it, you really need somebody else telling you when the patient is breathing in, because what we want to see is that when he's breathing in, the laryngeal folds should be moving, and they're not in this case, confirming that suspected diagnosis. This dog had a history of snoring, which was a new problem. Now, because of the close association with other nerves, particularly at the area of the jugular foramen and in the vagosympathetic trunk, then you will often see other neurological deficits associated with vagal nerve disease. And the most important of that is a Horner's syndrome. So this is sympathetic, meiosis, ptosis, enophthalmos, and protrusion of the third eyelid. Glossopharyngeal problems, so dysphagia, reduced gag reflex, loss of pharyngeal sensation. Accessory nerve, so this will be the atrophy of some of those shoulder muscles. In humans, these are meant to be the muscles that you use to shrug the shoulders, hence the name of this presentation. And the hypoglossal nerve, which is innervation to the tongue. And you can see this dog here has a much more classic hypoglossal paralysis. We can see atrophy of one side of the tongue and deviation towards the side of the lesion. Here's another example. So this cat here was presented to their local vet with signs of lethargy and anorexia, and the vet noticed this anisocoria, which he diagnosed as a right Horner's syndrome, and he did a GA to investigate the cat. That's included these chest radiographs, and he noted that there was no movement of the right vocal fold, and so he diagnosed a right laryngeal paralysis. And as we can see in this cat here, is an area in the cranial mediastinum, which has some opacity here, suggesting a mass, and that is in the area of the vagosympathetic trunk. And this was aspirated and turned out to be lymphoma. So the accessory nerve, the external spinal branch, I've said the internal branch joins the vagal nerve. The external spinal branch comes from the C1 to C7 spinal segments. You can just see it, those little rootlets joining up there. And then it goes back into the skull through the foramen magnum and joins the internal branch, exits through that jugular foramen and the tympano-occipital fissure with 9 and 10, and it's innervating the sternophalicus, the cleidocephalicus, the oma transversus, and the trapezius muscle. And if these muscles are atrophied or damaged, then the head will deviate towards the intact side. And this is because the contralateral sternophalicus is intact, and you get a shoulder drop ipsilateral to the lesion, which is an ipsilateral trapezius paralysis. And in reality, what the owners tend to report is a head turn or head tilt. It's difficult to get those images, and I'm going to recommend an article at the end that shows these images very nicely, but this is in our guy that I showed you earlier. Unfortunately, he has a neuroendocrine tumour which extended into the crania via the jugular foramen, and in my experience, this is a rare disease, but the most common cause of vagal nerve deficits. And the tumour kind of interferes with our assessment of the muscles, and I might be wrong here, but this is the cleidocephalicus muscle, and I think you agree that this muscle here on the right is smaller, although I will concede that it could be the tumour that's affecting that. And then we have the sternophalicus here, and then in comparison on the right here. So maybe explaining that dog's head turn to the opposite side. So what is the imaging of the vagal nerve that we need to make sure that we cover? And I'm going to be using some examples of pathology here. So this is the neuroendocrine tumours. So this is thyroid carcinoma or carotid body tumours, paragangliomas, often very difficult to tell the difference. They, from a cytology point of view, they look very similar. If you've got a very good radiologist, as we have, they may be able to spot the normal a thyroid gland in amongst all of this, and it should be said that carotid body paragangliomas are much more likely to invade up, and you can just see this is the tumour invading up through the jugular foramen and also into the spinal canal. That's the temporal bulla there, so it's going up into the tympano-occipital fissure here. I'm also going to touch on vagal nerve sheath tumours, another rare one, lymphoma, more common, and we're going to at the end talk a little bit about congenital or acquired laryngeal paralysis that is due to polyneuropathies. So this is our guy here, that our male neuter beagle, and he had the tumour around the glossopharyngeal, vagal and the accessory nerve passing through the jugular foramen. So here you can see the nerve in profile, as I showed you before in the sagittal image, and here you can see it going up through the jugular foramen. Compare that to the normal side here. This is what the normal nerve looks like, and this is what the abnormal nerve looks like, and there is a mass that is was going into the tympanic bulla as well in this dog, and a mass really at this involving all of these nerves, and they kind of spread along the nerves. And if you did a CT, then you may notice that the jugular foramen is widened in these instances. This is the normal here, this is the tympanic bulla there, and you can see this obvious widening there. If you follow the vagal nerve back, then if you remember those images that I showed you that comes out of the tympanic fossa and goes along the ventral surface of the atlas, and this is the tumour here extending down the atlas nerve, the vagal nerve. This is the normal side here. And at this point it's joined the cervical sympathetic trunk, and now it is the vagosympathetic trunk, which will continue down the neck in the jugular groove deep to the sternocephalicus and the brachiocephalicus. So the next part of imaging should, if you're investigating a vagal nerve problem, should be to image the neck. Here's some more images of that little guy, and we can see that the mass is involving the accessory nerve rootlets here at the side. We can also see it here. If we do that in a dorsal image, so this line here represents the dorsal image, we can see the bulbar area of the brainstem here, the spinal cord here, and here is the rootlets of the accessory nerve, which has been infiltrated with the tumour. We can also see in this little guy here the tumour which is around the trigeminal nerve branches on the skull base. So, as I said before, we need to extend the imaging down the neck, and in this guy there was a tumour that involved the vagosympathetic trunk, which was grossly thickened here. And there was a large mass at the thoracic inlet. This is it here, resected. So this is the thickened vagosympathetic trunk going off here. And this was between the common carotid artery and the right subclavian, right vertebral artery, and the mass extended to the heart base, and so for that reason it was thought probably to be a chemodectoma or a paraganglioma, but unfortunately we didn't get histopathology on this for various complicated COVID-related reasons. This guy had actually a 12-month history of a Horner syndrome and a 6-week history of gagging and coughing. This is an example of that cat that I showed you earlier. This is its MRI scan, and we can see this is the trachea here, and so the vagosympathetic trunk will be kind of running in the jugular furrow, which is either side of the trachea, and we can see this lymphoma extending up in this region here. This is the cross section through that region, this trachea here, and then this is the mass here. This is part of the crania, part of the lung here. The other way that we can investigate vagal nerve problems is by, specifically when there is a laryngeal paralysis, is by doing EMG of the intrinsic laryngeal muscles. Now, it should be said that laryngeal paralysis should not be considered the same as vagal nerve paralysis. And this is because the left recurrent laryngeal nerve and the right is the longest nerve relative to its target. You think it's going from the brainstem to the thorax and then loops back to the larynx. And this makes it very susceptible to disease that will affect multiple nerves. In polyneuropathy, the larynx is often the first affected. That older Labrador that you're seeing with laryngeal paralysis, I can bet you your bottom dollar that I would be able to find evidence of other polyneuropathy in it, just not clinical yet. And also that laryngeal paralysis affected older dog may not just be weak because they are dyspneic, but maybe weak because they have a generalized weakness as well. The sciatic nerve is the kind of next longest nerve that I see affected, and the way to test for a pathology in that is to see that there is a reduced withdrawal reflex, especially distally, so the hock failing to flex, but the stifle flexing normally. And this is because of dying back pathology. The way I try to explain this is if you imagine a tree that is trying to get nutrition from its roots all the way up to its leaves, and it has a problem transporting that nutrition up to its leaves, which leaves are going to die first? Yes, the leaves that are furthest away from the roots. And so we tend to see that the pathology affects the longest nerves first. And a fun fact is that in giraffes, this nerve can be almost 5 meters long, 15 feet long. But the interesting thing is that giraffes, as far as I'm aware, are not predisposed to laryngeal paralysis like some racehorses are. So it's not just a feature of length, it's down to pathology. So when we're investigating laryngeal paralysis, we'll often use electromyography of the intrinsic laryngeal muscles like this. So that noise you can hear is prolonged insertional activity and denervation potentials, which you can see here, characteristic of denervation. Which can tell our colleagues that are investigating that disease or proposing doing surgery that this is confirming that the muscle is denervated. We can also go on and do the rest of the muscles and do some nerve conduction velocities as part of a complete workup in these polyneuropathy cases. So this may be useful in vagal nerve disorders, but we most commonly use it when investigating polyneuropathies that include a laryngeal paralysis. And that really concludes this little jaunt through the vagal nerve. I'd like to recommend these excellent papers for your further reading, especially if you're doing your board exams for neurology. And so this lovely paper really showed very nicely the atrophy of the trapezius muscles, the drop shoulder. For us neurologists to get it, we would have to continue the imaging right the way down to the shoulder, which we're not likely to do in MRI. And then this lovely paper with multi-center study describing jugular foramen syndrome and the imaging findings and clinical signs. So in summary, the vagus nerve is a mixed cranial nerve, motor, sensory and parasympathetic. Its main functions are swallowing, vocalization and the thoracic and abdominal viscera, and of course keeping the larynx open so that you can breathe. Clinical signs are stridor, dysphonia, dysphagia, gag deficits, cough, possibly megaesophagus. When we see pathology of it, unfortunately, it is tumours, especially neuroendocrine tumours like thyroid and carotid body tumours, and we may also see the recurrent laryngeal nerve affected in polyneuropathies. The accessory nerve is motor only to the shoulder muscles. When we see clinical signs, we may see a head deviation away from the lesion and ipsilateral shoulder drop. It's a rare deficit to see, but we do see it very commonly when there is jugular foramen disease and sometimes some craniospinal lesions. Key points is the vagal and accessory nerves are closely associated and they exit via the jugular foramen. You may often see them with other cranial nerve deficits such as the Horner syndrome, especially with the vagosympathetic trunk, and the glossopharyngeal and the hypoglossal with the jugular foramen. And the recurrent laryngeal nerve, longest nerve relative to targets, vulnerable in polyneuropathies, and we'll use EMG of the intrinsic laryngeal muscles to help confirm denervation. Thank you very much.